Hi everyone, happy Monday. Good to have you all here. We're going live today with Dr. Kelly Casperson, a urologist, a specialist in hormones for women. So if you had any questions, make sure to write it in the comments or in the question bubble. We don't have much time, very limited. Dr. Casperson has only 30 minutes today, so we are going to start our conversation, but do feel free to write any questions, and if we had a chance to go through them, that would be great. So if you just hear me, I just want to make sure that you can hear me, if you can wave, if we have a good connection. That's great. Okay, I'm going to invite Dr. Kelly now.
Yay!
Hi.
Good morning.
Hello. Great to have you finally.
Thanks for having
I
me.
know you're so busy, and it's great to have you. We are both passionate about empowering women, so it's great to have you here today.
Totally. Nice to meet you. Happy to be here.
So just before we start, I wanted to share with you this patient of mine who I saw about last week, a few days ago, a 46-year-old woman, and she has all the symptoms of perimenopause, hot flashes, night sweats, and insomnia, and no sexual desire whatsoever. And guess what? She goes to see the gynecologist. She still has irregular periods and hasn't stopped her periods. And she was told by this gynecologist, what you're feeling is absolutely normal and natural. You have to feel like this. And you can go and use some herbal remedies. Once you stop your periods, you can come back and we can talk about the other options. Unbelievable. So she came to see me. I mean, it's great that she managed to go and find help and started hormones, but it's still, we see in this day and age, with what we're doing on these platforms and trying to empower women to advocate for themselves, but still having these cases. I don't know, what are your thoughts? Do you still see these kind of stories or hear the stories like this?
Yeah. Oh, yeah. Every day. I mean, there's 50 million midlife women, right?
Mm-hmm.
So 50 million midlife women in the United States of America, there's 1 million physicians total. It's not counting nurse practitioners and other prescribers. But it's like, this is going to take a while. But the good news is it's starting.
Mm-hmm.
And women are being empowered. I think that there is a lot of crap on the internet,
Mm-hmm.
but they're starting to figure out that there's like legitimate health things going on. What they're experiencing is not something to just suffer. The medical society tends to make women suffer longer and more than we make men suffer. So there's a gender bias.
Mm-hmm.
You know, if a man went in complaining of the same things, nobody would tell him just put up with it for a while and then try some herbal supplements. Zero people would tell a man that.
Mm-hmm.
So I really see caring for women in a gender equality lens. I'm a urologist, right? So I'm not a gynecologist. I do see all genders,
Mm-hmm.
and I see that we don't treat people equally.
We don't. I mean, it's good. Here in Canada, I think maybe around 10% of women are on hormone replacement therapy. I mean, still we have plenty to do, and we see how much the benefits outweigh risks. But still, we see lots of hesitancy with all those studies many years ago, and not only patients and women, but we see in doctors the providers, healthcare providers, they're still not feeling confident. So I think it's very important to just continue with these educational videos and social media platforms.
Yeah, I mean, I hear from Canadians all the time, and they tell me, this is not my opinion. They tell me it's worse in Canada than America. I'd be impressed if 10% of Canadian midlife women were on hormones, because It's not 10% in America. It might be 10% in the UK now.
Mm-hmm.
America's probably 5%. It's hard to count because so many of our products are compounded, so
Yes.
they're hard to record and measure. But it's certainly, somebody today is like, you're just telling everybody they should be on hormones, and I'm like, first of all, no, and second of all, only 5% of women are actually on hormones. And let's talk about how many women are on antidepressants. 25%, right? So we're by no means equal if you look at medications that women are on.
Yeah, and then we hear over medicalizing or over prescribing hormones. Yet we see so many women on antidepressants or bone medication, painkillers for aches and pains, and so many other medications.
Yeah.
It's
yeah. I mean, it's really, I think it's, I don't know, paternalistic maybe, but to say we're over medicalizing this, but we're not over like we go to the doctor for dry eyes. That's not life threatening. But we don't say, oh, we're really over medicalizing dry eyes. We acknowledge that people's concerns are legitimate, except for this concern, we really dismiss it. And it doesn't hold up to everything else.
Yeah. It's true. Yes. So you prescribing hormones, estrogen, progesterone, testosterone to women and men. So any age that you start them, is it any particular age, like 12 months after period, or any, just let us know a little bit about your approach.
Yeah. So the myth of the period, right? It needs to happen. So anybody who says that periods are a marker of when you should start hormones isn't thinking very deeply about hormones, because what do women with hysterectomies do? What do women with IUDs do? What do women with uterine ablations do? They don't have any periods. Do we tell them they can't start hormones, or do they get a free pass on hormones because they're not bleeding? Mm-hmm. Right? So number one, we're not thinking very deeply when you hold up the candle to all women who could benefit from hormones. Number two, you're not a hormone expert if you don't understand what hormones do before the periods end. And the periods ending is a marker of low hormone status, but periods end much later for most people than when the hormone fluctuations start happening. And remember, a lot of our symptoms are from fluctuations in hormones in perimenopause, not just low hormones. So what do we do with birth control pills, right? 80% of American women at one point have been on birth control pills, but nobody says we're over medicalizing birth control pills, right? We put people on birth control pills not only to prevent pregnancy, but to even out hormone fluctuations, which is why women get symptoms in their monthly cycle. Her birth control pills flatten out those hormone fluctuations. Well, that's what hormone therapy does in perimenopause and menopause, but it uses a natural hormone, not a synthetic like a birth control. If you don't need to protect yourself from sperm, you don't need to be on a birth control pill. Much higher dose, increased risk of blood clots compared to menopause hormone therapy. And if you have no worries about getting pregnant, don't be on that medication, right? If you don't need to be. Can be useful for heavy periods. But I want to use that as an example. Say, why do we use birth control pills? To flatten out the symptomatic fluctuations. So what do we do in perimenopause? We want to mellow out the symptomatic fluctuations. There's no reason a woman has to suffer until her periods stop. It's the fluctuations that cause the symptoms. Treat them. The period is irrelevant.
I see a question again, and that keeps repeating about when is there upper age when we would no longer prescribe estrogen and progesterone for women. It's just, I mean, I don't think there's any age limit.
Yeah,
if one feels good and there's no risk, why should we stop something that is helping?
Yeah, I mean, it's two different questions, right? So one question is, at what age do you stop? By and large, everybody agrees if you're doing well and your benefits outweigh your risk, take it to the grave. That's a pretty simple answer. The second question is more interesting. The second question is, what if I've never started and now I'm older? Will I get benefits? right? And is it safe to start? That's the more nuanced one. People will take, so the current guidelines say when started early, which means within 10 years of your last menstrual period or less than age 60, you have the biggest benefits to gain.
Mm-hmm.
And remember, hormones prevent disease, but hormones don't treat disease. So the older you are, without your body having seen the hormones, the more likely you have underlying cardiovascular disease, the more likely you have underlying changes that are progressing to dementia. Remember, dementia starts about 20 years before you actually get a first sign, right? Kind of like heart disease.
Mm-hmm.
So if you're, let's say you're 65, you are in the older category, you probably won't get as big of a benefit. Now, that doesn't mean that you're not going to protect your bones with it. Doesn't mean it's not going to help musculoskeletal aches and pains. If you're still having hot flashes, it's going to help that. So you can still get a benefit, but you aren't likely going to get those protective benefits that come with the data that shows the earlier the better.
Absolutely. I mean, I see patients sometimes, they're 70s, suddenly at that age start having hot flashes because of these fluctuations. So it's I mean, debilitating hot flashes. So it's worth, and it definitely helps them to go on HRT.
Yep.
So I don't see any reason we can't start later.
Yeah. Yeah. I mean, there are some absolute contraindications.
Mm-hmm.
They're pretty darn rare. Severe liver failure, undiagnosed vaginal bleeding, recent heart attack or stroke, right? So see a specialist if that, but that's a very small group of people where the risk outweighs the benefit.
Especially that nowadays, most of us prescribing transdermal bioidentical hormones. So again, the risks are much lower.
Much lower.
So can you be on testosterone without being on estrogen and progesterone?
Yes. It's not against the law. It's a little unorthodox. Is a lot of people will say, you know, why do you want to be on testosterone, right? Is it for libido? So I always want to know more information when people are asking that question. Why can't you be on estrogen and progesterone? Why would you only want to take one hormone? And that's what the clinic visit's for, right? Of like, to really understand people's why to these questions. But most people will get you settled on estrogen, progesterone first, then add a testosterone. But you don't have to. You're not breaking a law by only. Same with people like, I just want progesterone. Okay. But underneath that is an underlying, like, what's their understanding of hormones? What do they really want this for? You know, that's where the clinic visit is. You're going to go deeper on those questions.
Mm-hmm. So let's talk a little bit about local estrogen. I mean, again, there's so many women with, and you're the urologist, so lots of problems, pelvic floor, prolapse, and so many, I mean, so many symptoms that can affect and impact their life, day-to-day life. And we can prevent with estrogen. What are your thoughts on estrogen therapy, local estrogen, and if you can explain a little bit about that?
Yeah, so for people to understand, there's two main types of hormone therapy: systemic, meaning it's going in all tissues of your body, and then local. Some people in America, we tend to call it vaginal estrogen, even though I like putting it on the vulva as well, and it helps the bladder. Mm-hmm. But that's kind of how it's documented as vaginal estrogen. So that's local. It's not going to increase your blood levels of estrogen. It won't protect your heart. It won't protect your brain. It won't protect your bones. It is so low dose. It's only affecting the tissues that it's in contact with. It's not a preventative medicine. It's not FDA approved for prevention, but we know it prevents urinary tract infections. We know it treats overactive bladder, urinary urgency. We know that it helps treat, pain with sex, burning with urination, getting up at night to pee, all those things. So really, and the safety of it is it's so safe. And really the experts do talk about it as, hey, if genital urinary syndrome of menopause is going to happen in 50 to 80% of people after menopause, why not give them a local, safe, cheap medication that can, why wait for a woman to suffer before we treat her? And then once we've treated her and she's doing great, we don't tell her to stop it. So we're actually keeping her on it as a preventative medicine.
Yes. Yes. And someone was asking about, do they have to be on progesterone to protect uterus once on local estrogen? Or no? No.
It's so low dose. You know, somebody did a calculation, and the amount of vaginal estrogen in 1 year is equivalent to 1 pill of oral estradiol. So hundreds of times a lower dose. It doesn't stimulate the endometrium. Certainly, if you have unexplained vaginal bleeding, you're going to get that worked up. But by and large, the current guidelines are you do not need to be on a progesterone.
It's just what I keep hearing from women. I don't know your experience, but a lot of them complaining about how messy it is and they're not feeling comfortable with using estrogen. So I see a lot of them not compliant with medication just because it doesn't feel comfortable.
You usually just need some more education then, right? First of all, I like to remind people, do you remember how messy your vagina was when it was 22? They don't remember. It was messy. Right? Healthy vaginas have discharge. So that's number one. Number two, put it in before you go to bed. That way it's going to work its magic while you're sleeping. You're going to pee it out and clean it up on your first trip to the toilet in the morning, and then you're fine. Right? So put it in before you go to sleep. And number three, if it's still really goopy, you're probably just using too much. So use less. But I have the cream bias, because I like to put the cream on the labia minora and the clitoris, especially entrance of the vagina, the 6 o'clock, very common, tender, painful tears with sexual intimacy. I love that the cream, you can put the cream on there like face cream. And I think that the vaginal tablet, by and large, is too low a dose to really get the vulva structures like the cream can.
Good to know.
Also, in America, at least, the cream is the cheapest.
And how frequent? Normally it's twice a week. I don't know how frequent you if
normal is twice a week. Some people need it more. Some people need it less, but standard is twice a week. See how you do.
Yes. Now shall we get to the juicy part of talk, testosterone? That's a big T that everyone wants to know about it nowadays.
I have a question for you. How can you access testosterone in Canada? Are you using a male topical dose? What are the Canadians doing?
Male topicals or compound?
You can compound in Canada.
Yes. I do ask the compounding pharmacy, and patients been happy. Good.
Okay, awesome.
Yes.
So your access is pretty much the same as ours.
Yes, we still not have the FDA approved medical for women test here.
Yeah. I mean, my opinion is we will get the FDA approved one. It's probably 3 to 4 years from now. It's only going to be approved for, it will be approved for low desire. So you're going to have trouble with insurance coverage for that, because a lot of insurances exclude sexual health. And number two, it's going to be expensive. So getting a male product and dosing it appropriately is still going to be the cheaper option. So to me, I'm like, why wait for the FDA approval if your insurance still won't cover it, and you're going to get a cheaper product if you just dose the male product 1/10 the dose.
So again, it is approved for sexual desire dysfunction or disorder. So again, how we're going to quantify that? It's very, I mean, I feel it's not ethical to wait for women to go to that state of mind and distress, losing relationship, and then start her on this medication. I don't know exactly where this comes from, but it doesn't feel ethical, at least as a doctor, to wait that long. I don't know what your thoughts on that.
I mean, you bring up a really fair point, because what men never get asked in the doctor's office is, are you suffering enough? Men don't get asked that. We believe them when they tell us something, and we're like, it must be bad because you're here talking to me. women get asked so many times, are you suffering enough? And one of the hallmarks of, you know, the diagnosis of hypoactive sexual desire disorder is that it is low desire, both responsive and spontaneous, but also that it's distressing, right? And we have to believe women when they say it's distressing. How many women are going to go in saying this is distressing, and they're going to be like, but is it really a problem? You know, so it's like this extra barrier to care that I don't think men have to jump that hurdle.
Exactly. So there's so many questions here. Someone is asking about the IM injection. Do you prescribe IM injection?
Very rare
for women?
Yeah, I think the transdermal testosterone product is lovely, and it is a very nice, safe dose. It's very hard to get too high of a dose on that. So if a woman comes in and she's already on injections from somebody else and she just wants to keep that going, I'm not opposed to it. Usually a once a week injection, but a lot of people don't want to inject themselves if there's a daily transdermal. But some people think that's more convenient, right? It's easier to remember a Sunday night injection than a daily dose of something. So not inherently dangerous if it's dosed appropriately, but I would say it's the rare modality.
And then the side effects, someone is talking about the hair, the growth of hair in between the thighs. If anything we can do about it, it's, I mean,
yeah,
so
hair loss is a big deal for midlife women. It's multifactorial, as you know. Hair loss is actually very complex. I wish there was more dermatologists who specialized in midlife hair. That would be fantastic.
Yeah.
But hair is very sensitive to drastic changes in hormones. It's not specifically that testosterone's too high. It's a drastic change. And so to me, I'm like, if you're going to supplement with things, that's why we do one thing at a time often, right? See if you tolerate it. And I see it a lot more in the pellet people because they're going from a very low testosterone to a very high testosterone. It will shock the hair follicles. But that said, I defer to the dermatologists. I'm like, they're hormone, thyroid, vitamin, your diet's, you know, not healthy to promote growth. There's so many things with hair that I don't give all the credits that hormones are going to make it better, and I don't give all the credit that the hormone is the only thing that makes your hair have hair loss. So hair's complicated for sure. And anybody who says you just need more estrogen or you just need less testosterone, you're oversimplifying hair.
Again, I see a lot of women after starting estrogen, they feel much better with the hair texture. They feel it's improving, but as you said, there's so many different factors involved in hair. So with testosterone, so we want to start a treatment women on testosterone. So do you do blood tests beforehand and after? And if yes, what are the tests you want to check just to be unsafe? And
yeah, I do a total testosterone. Make sure it's the female total testosterone, because that's the mass spectrometry lab test, which is more sensitive to lower values. And even then, I don't think these tests are specifically that accurate, but it's good to have a baseline and to make sure you're not having somebody who has a high testosterone that you're just not picking up on. I haven't seen that person yet, but they're out there. And then you want to recheck your testosterone around 2 months after you start your testosterone to see where you are with that. Make sure it's not too high. Check in, make sure she's not having side effects, and see how she's doing on it.
I agree. Someone has unexplained vaginal bleeding, ultrasound, increased progesterone. So asking which of these she should do with unexplained vaginal bleeding, decreased estrogen. I mean, it's common to have bleeding post starting hormone replacement therapy. I've seen within a few months, they have some bleeding. But again, what are your thoughts and investigations?
Yeah. I mean, say somebody's newly menopausal, so they're 13 months after having their last period. You start them on hormones, they have a bleed. That's not unexplained vaginal bleeding. That's, I started you on some hormones, so you're having a bleed, right? So true unexplained vaginal bleeding would be not related to you starting the hormones. Or maybe you've been on hormones for a long time, now you're bleeding. Then you need to get that worked up with an ultrasound. I'd say a referral to a gynecologist. And once you realize that, everything looks fine and you're bothered by the bleeding, you can adjust doses. So especially if you're in the early menopause thing, they'll say, you know what, just continue on your dose for a while. This should mellow out within 6 to 12 months. But certainly the party line is don't ignore it, especially if you haven't had periods for a while and it truly is unexplained vaginal bleeding.
Agree. Someone is asking about HRT and testosterone in case of triple negative breast cancer survivor. Is it safe? What's the general approach?
Yeah, so there's data. There's data on triple. Of course, we need more studies on everybody. I'm never going to say we have everything we need, but there is data to say that triple negative breast cancer survivors have no increased risk over the general population for hormone replacement therapy.
Yeah, absolutely.
The problem is that breast cancer, which is 20 different diseases, gets lumped into one statement of breast cancer, right? And so you really need to see somebody who understands hormones, who understands, so you can see what kind of breast cancer you had, is it safe for you, and certainly at some point we'll be more specific with these diseases, but all breast cancer is not created equal.
Yeah, it's like prescribing any other medication. We want to check, and it's very individualized. We have to go by case. Each case is different.
Yeah, but just in my experience, I have a couple of women who are triple negative, and they were suffering. To say that they were at like extreme suffering, and came in, started on hormones, and they're doing incredibly well.
Yeah. HRT, someone on HRT, estrogen and progesterone for 3 weeks. When is a good time to start testosterone? And should she wait to see how she reacts to those two first?
Yeah, I mean, this is how I do it, and certainly a lot of menopause experts will do it the same, is get people happy where they are on their estrogen and progesterone, then add testosterone. Some people will start everybody on everything all at once. If I have like a lot of people who come see me, they're very educated. They listen to my podcast, they've read my book, they follow they know. They know the difference between vaginal and systemic. They know all of that. And so I'm comfortable, especially if they're coming from far away to see me, I'm comfortable being like, here's the vaginal, here's your estrogen, here's your testosterone. Because I know that they already are so comfortable with the idea of everything. But if it's somebody who's brand new to stuff and I feel like I'm going to overwhelm them, there's no reason not to go slow on this.
Yeah, I normally do the same. I normally start with estrogen and progesterone and wait for a few months just to see how they feel, if they're symptom free or if we still have to fiddle around with the doses or adding testosterone. I do the same thing.
Cool.
So I'm going on 12 weeks on medications, and I'm a stroke survivor, so I have transdermal patch, progesterone gel, take at bedtime, and compounded testosterone cream applied daily to the wrist. So I don't know if this was a question or just.
I mean, we can mention progesterone gel, right? So progesterone gel, progesterone is a large molecule. This is a 20 carbon molecule. It's bigger than testosterone and estrogen because you actually get testosterone and estrogen from progesterone, right? It's such a big molecule, you can't get enough through your skin with a transdermal progesterone. Now you can buy stuff that says progesterone on Amazon, but it's not medical grade, and it might help your hot flashes because you're getting some of it, but it's not enough to protect the uterine lining. And there are published studies saying women who use compounded progesterone cream have a higher risk of uterine bleeding and even uterine cancer. So most hormone experts will say there are legitimate options for progesterone, but a cream off the internet and even a compounded progesterone cream is not standard of care.
It's not. I mean, I always prescribe oral progesterone. I mean, in some cases, women still have their IUD with progesterone, which would protect them until they remove it. I think that would be good too. What about DHEA? Is that over the states? Do you have to prescribe it for vaginal atrophy, the symptoms of genitourinary?
Yeah, it's interesting here. So DHEA in the vagina is It's a beautiful thing.
Mm-hmm.
DHEA is a precursor hormone. It converts to testosterone and estrogen. There is a prescription in America called Prasterone or Intrarosa. All it is DHEA. It's a vaginal suppository. It is amazing. I love it. The downside is it's expensive, right? Now, interestingly enough, in America, we also have over-the-counter oral DHEA, and we have over-the-counter vaginal DHEA. There's a brand called Beswicken. You can get it on Amazon, but there aren't studies. And so, like any supplement in America, it's unregulated. You can't actually trust that what's in it is what's in it, right? But it's cheaper. So it's really a buyer beware. And I would say, you know, go in with your hormone expert and say, hey, can I try this because it's cheaper? Let's see if it's as good as this other stuff. As far as oral DHEA in the vagina, that's been mentioned. It's cheap. We don't have studies. And again, it's a supplement. So buyer beware, probably not dangerous. But then there's oral DHEA orally, which I think the data is very mixed on. It hasn't proven to be very beneficial and certainly isn't a substitute for medical grade hormones.
Very good point. Yes. And then other medications, non-hormonal, if you just touch base on those for sexual desire and libido, that would be helpful too.
Yeah, so there's two in America, there's two FDA approved medications for hypoactive sexual desire disorder, aka low libido. One of them is a daily medication you take at bed. Side effect is sleep. So people sleep better on it. Also, side effect is a little bit of weight loss. So most people tolerate it. Some people get really groggy or nauseous on it, but not everybody. So that's a nightly medication that you take every day, and it doesn't work in everybody, but the people it works in, they love it. And the experts think about 60% of people are responders. So I have seen it covered by insurance, which is nice, not everybody. But I think it's a safe drug. I think that I've got happy people on it, and that is called flibanserin or Addy, ADDYI. You can go to addy.com to start a prescription on that and learn more about it. The second one is called bremelanotide or Vyleesi. That is an on-demand injectable dose. So they say inject about 45 minutes prior to sexual activity. Some people do take longer to respond. You know, you hear about somebody injecting it, then they wake up 4 hours later, like ready to go. So you might need to fiddle around to see how long it takes you to respond to it. Both of these medications work by increasing dopamine in the brain. So non-hormonal, they are FDA approved for premenopausal women. I have not seen, my insurance companies aren't calling my women and saying, when was your last period, right? But an insurance company could say it's off-label for postmenopause, but we do have data in that age range that it does work. The injectable one, higher risk of nausea. So some people will prescribe ondansetron or an anti-nausea medication with it. But they're both good options. Libido is complex. There's many, you know, sex is biopsychosocial. So stressors, overall health, relationship issues, are you sleeping well? Do you just have menopause symptoms that need to be treated? So many things go into libido. But certainly if you have a woman who's like, my relationship's great, I'm not that stressed, I just want to want, this is where these medications are, they shine for that scenario.
Yeah. I know you're in a rush and you have that 30 minutes, but we can go one last question, if you don't mind. Could you add oral progesterone if you're using estradiol patch and have a hormonal IUD?
Yeah. So, you know, I think progesterone got a bad rap because of the WHI and the medroxyprogesterone acetate, and it was really only used to protect the uterus, you know, if you had a uterus and were taking estrogen, right? Because for anybody who doesn't know, it's not good to have unopposed estrogen when you have a uterus for hormone therapy. You need a progesterone. So because of all that and the scare of maybe the medroxyprogesterone acetate is actually the breast unsafe medication, people are saying just take it if you have a uterus, take it for the lowest dose, and only you get it and nobody else gets progesterone. And now we know that progesterone is incredibly important in the body. It actually has bone protective effects. It has mood protective effects. It is an anti-anxiety med. It's wonderful for sleep. It's very calming. And it's incredibly safe. We've got lots of data saying oral micronized progesterone is incredibly safe and it's breast safe. Mm-hmm. So I think the answer is yes. You can have an IUD that's a progestin secreting to protect your uterine lining, and you can also take an oral progesterone on top of that for the progesterone specific benefits.
Very good. If dosage needs to be adjusted between progesterone or estrogen, how do you know which needs to adjusting or the adjusting?
Yeah, I mean, that's really a conversation, an individualized conversation for a woman in clinic.
Exactly.
We're not Toyotas, we're not cookbooks of what are her goals, what symptoms does she want to see improved. That's a really individualized question. The answer could be either.
Yeah. And yes, it will be available, this talk, to listen again.
Yay! I want to mention two things to your listeners. Number one, it's going to be on the internet, so Canada will get it too. But on October 18th, which is World Menopause Day, a documentary is coming out on PBS, and it's called The M Factor. And it's all about menopause and what we've done in this country and what we've done to women and the people who are trying to change healthcare for women. So I strongly recommend following that and watching that documentary when that comes out. And that if people want more info on sex med and hormones and lifestyle, pick up my book, which is releasing in September, called You Are Not Broken. Stop shitting all over your sex life. I discuss the medications, I discuss different types of desire, and really give us the education that we didn't get when we were teenagers.
Amazing. Lovely. It's great. It was lovely hearing you and having you here, Dr. Kelly. And hopefully
Thank you.
I'll see you in person sometime soon.
Absolutely.
Okay. Thank you very much. Have a
Yeah.
lovely day. Thanks, everyone.
Thank you, everybody.
Bye-bye.